Imagine going to the doctor with this burning fire on your skin. They give you a cream, the fire goes out, and the skin heals perfectly. But the burning pain, it never leaves.
Yeah. And in fact, it often gets worse. You can't wear certain clothes. Sitting is agonizing, and pain-free intimacy is just entirely impossible.
Right. And you go back to the doctor, they look at the perfectly healed skin, and they basically just shrug.
It's honestly one of the most maddening scenarios in medicine. The obvious cause is completely eliminated, yet the devastating effect is just, well, completely entrenched.
So, if you're a curious learner trying to unpack complex, deeply frustrating medical challenges, you are in the right place for today's deep dive. We're taking a stack of clinical guidelines, physical therapy protocols, and some really cutting-edge research papers to answer one highly specific question for you.
Yeah, we're looking at how clinicians manage secondary vulvodynia, or neuroproliferative pain, that just stubbornly persists long after the active inflammation of a disease called lichen sclerosus is totally controlled.
Okay, let's unpack this. First, we need to set the stage. What exactly are we dealing with here?
Right, so to give you the landscape, vulvodynia is a chronic pain condition, and it's a diagnosis of exclusion, meaning it's diagnosed only after everything else, like an active yeast infection or a bacterial issue, has been totally ruled out.
But we aren't talking about primary pain today, right? Like pain someone might have felt since the very first time they tried to use a tampon.
Exactly. We're looking specifically at secondary provoked vestibulodynia, or PVD.
Right. The secondary part means the patient had a period of completely normal, pain-free function in their life, and then a trigger happened. And in this case, that trigger was the chronic inflammation caused by lichen sclerosus, which is an autoimmune skin condition.
Yeah, and the active disease was suppressed by high-potency topical steroids. So the skin looks fine to the naked eye, but the legacy of that inflammation has fundamentally altered the tissue.
So before we even touch on how clinicians try to fix this, we really have to understand the invisible damage. I mean, if the inflammation from the LS is gone, what is actually causing this burning agony?
Well, the answer lies in a biological process called neuroproliferation. When tissue is chronically inflamed, the immune system dispatches its first responders, which are known as mast cells, right into the mucosal tissue of the vaginal vestibule.
And mast cells are basically little biological grenades, right? They don't just sit there quietly.
No, not at all. They burst open, and they release this massive cascade of inflammatory chemicals into the surrounding tissue. One of the most critical substances in that chemical soup is called nerve growth factor.
Which I'm guessing does exactly what it says on the tin. It forces nerves to grow.
Exactly. It causes a physical, measurable increase in the density of pain-sensing nerve endings in the vulvar tissue. This hyperinnervation means the body is literally sprouting new, highly sensitive nerve endings in response to the chronic inflammation.
Wow, it sounds like a house fire. The topical steroids act like the fire hoses. They put out the primary fire on the walls. But while the fire was burning, the intense heat caused the home's electrical wiring behind the walls to melt, short circuit, and multiply.
That is a great way to look at it, yeah.
So now the fire is completely out, but the smoke alarm is hardwired to blare at full volume even when someone just lights a tiny candle in the next room.
That captures the peripheral sensitization perfectly. The local wiring in the tissue is multiplied, and it's hypersensitive. What's fascinating here is that the research reveals something even more startling. The changes don't actually stop at the periphery. Secondary PVD physically alters how the brain processes sensory signals.
Wait, seriously, the structural wiring of the brain changes too.
Yeah. A 2023 study mapping brain networks in women with secondary PVD found significant increases in connectivity within the dorsal attention somatomotor network.
Okay, let's translate that dorsal network into plain English for a second.
Sure. Think of it as the brain's internal security camera system. Normally, the brain filters out background noise. But in these patients, the security cameras become hyper-focused on the pelvic region.
So they're watching for any tiny threat.
Exactly. There's a central amplification of signals. A very light touch that should register as normal, non-painful friction is captured by this hypervigilant network and instantly magnified into a severe burning threat.
But wait, if the brain networks are changing and the brain is actively magnifying the pain, aren't you essentially telling this patient it's all in her head? Because I can tell you right now, if a doctor told me my physical burning pain was just my brain playing tricks on me, I'd walk out of the clinic and never come back.
Yeah, that reaction is incredibly justified, and it is vital we debunk the psychosomatic myth right now. Women with chronic vulvar pain are tragically dismissed by uninformed practitioners who tell them to just relax or drink a glass of wine.
Which is just awful.
It is. The research emphatically shows this is a neurobiological reality. It is not an imagined pain, nor is it a psychological mood disorder. It involves physical, measurable nerve growth in the tissue, combined with structural, measurable network alterations in the central nervous system.
So it's very real physical hardware changes.
Exactly. It is in her peripheral nerves and her spinal cord. It is nowhere near, quote-unquote, just in her head.
Hey, and the sheer validation of reading that in a medical journal must just bring patients to tears. So looking at the treatment protocols, you have a patient with multiplied local nerves and a hypervigilant brain. You obviously can't just slap a basic steroid cream on multiplied nerves and call it a day.
No, definitely not. The clinical strategy has to pivot completely. You stop treating the skin and start chemically quieting the nervous system. Clinicians generally start locally.
And the sources make a point of warning against over-the-counter creams for this, right?
Oh, absolutely. Commercial creams are loaded with preservatives, stabilizers, and alcohol bases. Applying those to tissue that has multiplied pain receptors is literally like rubbing alcohol on a paper cut.
Ouch. So what do they use instead?
Clinicians rely heavily on compounding pharmacies to custom make pure treatments without any of those irritating additives. One of the standout local treatments mentioned in the Zollner study involves lidocaine, which most people know is the numbing shot you get at the dentist.
Right, but the application method they used in the study is pretty intense.
Yeah, they didn't just have patients rub a little cream on. The protocol instructed patients to apply copious amounts of a compounded 5% lidocaine ointment to a cotton ball, insert it into the vestibule, and just leave it there overnight.
Wait, every single night? For how long?
For an average of 7 weeks.
7 weeks of sleeping with a medicated cotton ball? Why does it take that long? I mean, why not just numb it right before intimacy?
Because the goal isn't temporary numbness. The goal is to chemically exhaust those hyperactive nerves. By bathing those multiplied nerve endings in an anesthetic continuously for weeks, you are blocking the sodium channels those nerves use to fire.
So they just get tired out.
Basically.
Yeah.
Over time, the constant blockade forces the nerves to downregulate. They finally stop firing the alarm. And the study showed massive improvements in the patient's ability to tolerate penetration.
Okay, so that addresses the melted wiring in the walls. But what about the security system in the brain? Lidocaine on a cotton ball isn't going to seep into the spinal cord or the brainstem.
Right. To address the central sensitization, clinicians have to turn to systemic neuromodulators. There was a recent clinical case series focused on 20 patients dealing specifically with vulvodynia secondary to vulvar lichen sclerosus.
And what did they use?
The clinicians utilized an oral medication called amitriptyline, which offered profound pain relief and dramatically improved their quality of life.
But amitriptyline is traditionally known as an antidepressant. And the sources also mention using gabapentin, which is an anti-seizure medication. If a patient has fought for years to prove her vulvar pain isn't a psychiatric issue, handing her an antidepressant feels like a massive slap in the face. How does a clinician even bridge that gap?
Patient education is literally the only way to prevent that breakdown in trust. The clinician has to sit down and explicitly diagram how the central nervous system works. They explain that these drugs are being used completely off-label at microscopic doses compared to what is prescribed for depression or seizures.
So, at a tiny dose, an antidepressant isn't actually altering your mood. What is it doing?
Well, imagine your spinal cord as a series of toll booths where pain signals have to pay a toll to travel up to the brain. Neurotransmitters like serotonin and norepinephrine act as the traffic cops closing those toll booth gates. Amitriptyline is a reuptake inhibitor. It forces those specific neurotransmitters to stay in the toll booth area longer.
By keeping the traffic cops at their post, they block the pain signals from getting through the gates to the brain. You are basically chemically turning down the volume of the central alarm.
Exactly. You are intercepting the signal before the brain can magnify it.
But chronic pain doesn't just happen in the nervous system. The muscular system gets dragged into this too. I mean, if you are walking around with burning vulvar pain for months or years, your body is naturally going to physically brace itself.
Oh, without a doubt. The pelvic floor muscles engage in this subconscious defensive flinch. And this is where pelvic floor physical therapy, or PFPT, becomes an absolute pillar of management.
Let's draw a hard line here based on the sources, though. Pelvic floor physical therapy does not treat the underlying autoimmune disease of lichen sclerosus. You cannot massage an autoimmune skin condition away.
Correct. What PFPT treats is the muscular fallout. Because the tissue is fragile and painful from the LS, the patient unconsciously guards their pelvic region. Over time, that constant guarding turns into chronic hypertonicity.
Meaning the muscles just get super tight.
Yeah, they go into severe spasm and literally forget how to relax. This causes radiating myofascial pain and physically narrows the vaginal opening.
Think of it like pulling the emergency brake on your car because you sense danger, but then the brake gets jammed. You can't just push the gas pedal and expect the car to drive normally. The physical therapist has to basically get under the hood and recalibrate the emergency brake.
That's a perfect analogy. And they use highly specialized techniques for this. They perform internal myofascial release. They also do scar tissue mobilization, which is vital because lichen sclerosus often causes anatomical changes, like the fusion of the clitoral hood or the labia minora reabsorbing.
So the PT is manually working to restore flexibility to that altered architecture.
Exactly.
The sources also emphasize biofeedback using a vaginal sensor. How does looking at a screen help a muscle spasm?
Well, the brain has lost proprioception. He doesn't even realize the pelvic floor is clenched. So the physical therapist inserts a small sensor that detects muscle electrical activity and displays it on a monitor. The patient can physically see a graph spiking when their muscles are clenched.
Oh, so they can visually connect with what their body is doing?
Right. By watching the screen, they can relearn the specific mind-body connection required to drop the graph, consciously commanding the muscles to finally let go.
Here is a glaring issue, though. We are talking about tissue that has been ravaged by lichen sclerosus. It's often described as thin, parchment-like, and incredibly easy to tear. Isn't inserting sensors, doing internal myofascial release, or using vaginal dilators incredibly dangerous for someone whose skin might literally split open?
This raises an important question, and it's a huge concern for patients. That fragility is the exact reason PFGT cannot happen in isolation.
Yeah.
It is framed as an adjunctive therapy requiring a tightly knit, multidisciplinary team.
So the physical therapist has to be in constant communication with the dermatologist or gynecologist who is managing the LS.
Exactly. They need to know the exact status of the skin barrier on any given week. The treatment incorporates education on hypoallergenic vulvar care and heavy use of specific moisturizers. The physical therapist guides the patient in using dilators in a highly controlled millimeter by millimeter fashion to gently maintain tissue elasticity without causing micro tears or fissures.
It sounds like an incredibly delicate dance between unsticking the muscle and protecting the skin.
It really is.
So we're putting out the fire, we're quieting the chemical alarm in the nerves, and we're unsticking the muscular emergency brake. But the clinical literature acknowledges a really harsh reality. Sometimes a patient does everything right, and the pain remains unbearable.
Yeah, unfortunately.
The physical neuroproliferation, that tangled, melted wiring we talked about earlier, is just too entrenched. Here's where it gets really interesting. What is the next move when the standard toolkit fails?
Clinicians turn to experimental therapies, lasers, and ultimately surgery. The experimental topicals are fascinating because they target the mechanism before the nerves even have a chance to multiply.
The clinical trials mention topical ketotifen at 0.25%, right?
Yes, ketotifen is a mast cell stabilizer. If the mast cells are those biological grenades we discussed, ketotifen basically reinforces the pin. It stops the mast cell from bursting open and releasing nerve growth factor, which cuts off the neuroinflammation right at the source.
And there's another emerging area involving SPMs, specialized pro-resolving mediators.
Right. The specific one being researched in this context is called Marizin I. SPMs are endogenous lipids, which are just naturally occurring fats in the body. If mast cells are the immune system's destructive SWAT team, SPMs are the body's natural cleanup crew.
So they're sweeping up the inflammatory debris.
Exactly. Their entire biological job is to actively resolve inflammation. In lab settings, they've been shown to reduce those inflammatory alarm chemicals. The massive advantage of using an SPM is that it initiates tissue repair without suppressing the patient's entire systemic immune system.
Which is the major downside to long-term steroid use, right?
Precisely.
The sources also highlight laser therapy. Now, I hear laser, and I immediately think of burning or cutting. How does a laser heal painful, fragile vulvar tissue?
It sounds counterintuitive, but observational studies are pointing to fractional CO2 lasers and blue diode lasers as highly effective second-line treatments for stubborn lichen sclerosus. They don't cut, they create controlled microtrauma.
Oh, so by slightly damaging the tissue, they force the body to repair it.
You got it. The microtrauma stimulates fibroblasts, which are the cells that build collagen. It also prompts the growth of tiny new blood vessels. This dramatically improves tissue trophism, meaning the actual nutrition, blood flow, and structural health of the tissue.
So patients report significant reductions in pain and itching simply because the tissue becomes robust again.
Exactly. But if the medications, the cleanup crews, and the lasers don't work, clinicians have to consider vestibulectomy, which is surgery.
Surgery is reserved for when conservative measures fail, but when it is utilized, the guidelines stress it must be a contemporary vestibulectomy. What separates a contemporary vestibulectomy from what surgeons used to do?
Historically, a surgeon might excise just the specific small patch of tissue where the patient felt the most pain. But our modern understanding of neuroproliferation tells us those hyperplastic tangled nerves are everywhere throughout the mucosal lining.
So a contemporary vestibulectomy requires the surgeon to remove all of the vestibular tissue.
Yes, the entire horseshoe of the vestibule.
Wow. You remove the whole area, but then you have a massive wound. How do they close it without causing catastrophic scarring?
They perform a vaginal advancement flap. The surgeon essentially pulls healthy, unaffected tissue from the intervaginal wall down to cover the area where the vestibule used to be.
Okay, so they rebuild the floor using healthy tissue that doesn't have multiplied nerves in it.
Right. And crucially, the surgeon cannot just stitch it to the surface. They must use anchoring sutures, tying the flap down into the deep connective tissues between the vagina and the rectum.
Why anchor it so deeply?
To prevent tension. If the flap retracts or shrinks as it heals, it will cause severe narrowing and a return of the pain. The deep anchors lock the new healthy tissue into place. When surgeons adhere strictly to these principles, the success rates for totally eliminating the pain are remarkably high.
The physical mechanics of that are just incredible, but I keep thinking about the human being going through this. We are talking about enduring years of burning pain, enduring the trauma of misdiagnosis, altering spinal cord chemistry, and eventually removing entire sections of tissue.
It's exhausting just to list it out.
Right. The emotional exhaustion and the strain on relationships must be completely devastating.
The psychological toll is immense. The guidelines are adamant that multidisciplinary care is entirely incomplete without addressing the mind. This involves cognitive behavioral therapy, or CBT, as well as psychosexual medicine or couples counseling.
Now, some might hear CBT and think, oh, so you do think it's just anxiety. But CBT for chronic pain is entirely different, isn't it?
Completely different. It addresses the mind-body feedback loop. When a human being experiences severe, relentless pain, it is completely natural to develop pain catastrophizing. The brain anticipates the pain, the body tenses up in fear, the tension restricts blood flow and tightens the pelvic floor, which in turn physically creates more pain.
So it's a vicious cycle.
Exactly. CBT teaches the patient to interrupt that biological loop. It tackles the profound demoralization and helps couples rebuild intimacy that isn't solely defined by penetrative pain. The data shows CBT physically reduces reported pain scores because it directly lowers the central nervous system's threat level.
To summarize this entire labyrinth, managing secondary pain after lichen sclerosus requires a highly coordinated assault. You have to control the initial autoimmune fire. You chemically reset the multiplied nerves and the spinal cord alarm using anesthetics and neuromodulators. You unstick the body's muscular emergency brake through specialized physical therapy.
Yep. And you explore mast cell stabilizers and lasers.
And occasionally, you tear down the drywall and rebuild the house entirely through surgery, all while providing fierce psychological support.
The complexity really reflects the reality of chronic pain. There is no single magic pill.
But having the vocabulary to understand this, knowing words like neuroproliferation and central sensitization, gives you the power to walk into a doctor's office and demand a treatment plan that addresses the actual biology, not just the symptoms.
If we connect this to the bigger picture, the research is actually pointing toward a massive paradigm shift in how we view this entire cascade.
Really? What's the new frontier?
The sources outline a fascinating hypothesis. Researchers are questioning the assumption that localized provoked vulvodynia is merely a localized pain syndrome. They are investigating whether it's actually an immune-mediated inflammatory disease driven by highly specific mucosal immune responses.
What kind of immune responses?
They're looking closely at CD4 Th17 cells and the IL-17 cytokine pathway.
Let's translate the cellular biology there. What are Th17 cells doing?
Think of them as a highly specialized immune hit squad. Instead of generalized inflammation, this hit squad sends out specific chemical text messages, called IL-17, that continuously trigger the tissue to remain inflamed and painful, long after the initial lichen sclerosus flare-up has passed.
So the body is actively choosing to attack that specific tissue over and over.
Right. But the truly provocative finding is the systemic connection. Studies are showing that patients with lichen sclerosus have remarkably high rates of systemic autoimmune diseases. We aren't just talking about the skin. We're talking about Hashimoto's thyroiditis, psoriasis, and pernicious anemia.
Wait, the localized burning pain in the vulva might just be the tip of a systemic autoimmune iceberg.
If we begin viewing this persistent pain as a red flag for a system-wide immune dysregulation, it revolutionizes our entire approach.
Because right now, a patient comes in with vulvar pain, and doctors usually only look at the vulva.
Exactly. What if, in the future, a simple blood test for thyroid function or vitamin B12 levels becomes the standard of care the moment a patient presents with lichen sclerosus? If we can identify and treat the systemic autoimmune markers immediately, we might be able to intervene before the mast cells ever drop their grenades.
Wow. Catching the systemic spark before it ever reaches the house, that completely changes the timeline of suffering. As you take this knowledge into your next doctor's appointment, or share it with someone you know who has been suffering in silence, remember this. The biology of this pain is real, the mechanisms are measurable, and the medical community is finally mapping the way out. Keep pushing for the care you deserve.